Okay, there we go. Okay, so I'm Taylor. I guess Vahle for now, even though my slideshow says Welch because I'll be changing my name shortly. Nurse practitioner in ICU, and I'm going to be presenting on cardiac arrest and targeted temperature management. So these are just some statistics about cardiac arrest that I got from the American Heart Association. There's about 356,000 cases of cardiac arrest in the US annually. 90% in fatality. Survival to hospital discharge after EMS treated cardiac arrest is only 10%, with only 8.4% of patients having decent functional status afterward. The initial rhythm for the arrest was VFib or VTAC in only 18% or 18.7% of cases. So after resuscitation from cardiac arrest, aside from just the hypoxia and the lack of perfusion, you have a post-resuscitation brain injury, which leads to damage at the cellular level. Cerebral ischemia happens. And then your glucose and adenosine triphosphate are depleted. The cells lose structural integrity. You start having brain damage, cerebral edema, and free radicals, which will then lead to further reperfusion injury. This is kind of a history of targeted temperature management, which also used to be called therapeutic hypothermia. So this came to light in the early 2000s when it was felt that after 2 very small studies, cooling patients would decrease your metabolism enough to kind of keep your brain function from completely going to, sorry, I'm having a stroke here apparently, from it's supposed to keep your brain function better. And so we had the Bernard trial, which was just 84 patients with initial rhythm of VFib or VTAC who achieved ROS but were comatose. And then there was another trial that was a little bit larger with 220 patients that showed a 14% absolute reduction in mortality after 6 months. This was in VFib and VTAC arrest only. These were not blinded studies either, and the results are a little bit skewed. And then in 2013, the TTM1 trial came out, and this trial evaluated whether there was a benefit from hypothermia at 33 versus normothermia. Involved more patients, 950 patients. And then we kind of just stuck with this targeted temperature management, usually cooling around 33 degrees from 2013 until 2021. The Hyperion trial came out in between that time, which recommended targeted temperature management for all forms of cardiac arrest, not just VFib or VTAC. And then in 2021, the TTM2 trial came out. This was a very large study for cardiac arrest patients anyway, and 1,800 patients that were compared at cooling to 33 degrees versus just maintaining normothermia. The control group was not placed on a cooling device unless they became hyperthermic, and that leads to, there's really no difference. There's actually no difference in all-cause mortality, modified Rankin score, and patients who were cooled actually had a higher risk of arrhythmia and hemodynamic compromise. So why the concern over to cool or not to cool? Hypothermia affects all organ systems. The colder the patient is, the more pronounced these issues are. A lot of our patients would get bradycardic. The bradycardia is refractory to atropine a lot of the time, results in decreased cardiac output and hypotension. So patients who were really unstable to begin with couldn't be cooled anyway because we just make them more unstable. The bradycardia would lead to torsades potentially, respiratory depression, decreased oxygen consumption, and increased or decreased CO2 production. You had a cold, quote unquote, cold water diuresis. So when you were cooling them, they diurese quite aggressively, which would cause electrolyte shifts. Shivering during the cooling process actually increases oxygen consumption and metabolic demands, which is counterproductive to what we're doing. So then we were having to give them medications, sometimes paralyzing them to keep them from shivering. There's an increase in hyperglycemia with your cold patients. They end up having bleeding issues, thrombocytopenia, sometimes DIC, gastrointestinal. You got ileus is developing, stress ulcers, hepatic dysfunction, sometimes pancreatitis can be a result of cooling. And then you had electrolyte disturbances, both hypo and hyperkalemia were major ones. So in the hypothermia group from the TTM2 trial, there was a increase in arrhythmia causing hemodynamic instability, 24% versus 17%. There was a much higher need for paralytic agents, and then the hypothermia group was on the ventilator longer. So the question is, are we never cooling anymore? The TTM trials have only studied shockable rhythms. They really haven't looked at PEA, even though there's still been a recommendation to cool any rhythm. So right now, there's no clear-cut recommendation for unwitnessed or PEA or non-shockable rhythms. Cooling to 33 degrees is not going to be beneficial. It doesn't really improve mortality, and it has a lot of complications. So for non-shockable rhythms, we're probably looking at maybe cooling them to 36 if we're going to cool them at all. People who are in VFib or VTAC arrest, we're probably not going to cool. We'll just maintain normothermia. They may still end up with a Zoll device. We had a patient in CVU a couple weeks ago, I don't remember, who was a cardiac arrest on an Impella, and he had a Zoll in, which was great because he got hyperthermic, and so I just had them turn that on and make him 37 degrees. So we really need to be avoiding fever for 72 hours post-arrest because hyperthermia is what's really going to cause the brain injury. This is just your nursing orders for your targeted temperature management if we're using it. A lot of these will still be in place even if we're just doing normothermia. We still want to monitor vitals like we're supposed to, electrolytes, labs. These medications will still be there because even if we take somebody who's hyperthermic and cool them to normothermia, they still have shivering issues, which we encountered with that patient. That's just your medications. So supplies for the Zoll catheter. There's the jugular and the femoral. So just make sure that when you're bringing the supplies to the bedside, you have the right one. It doesn't come with anything in there really, so we need all the sterile gown and sterile drape and lidocaine, and then temperature sensing Foley if they're making good urine output. They have to have 2 temperature sources. So post-cardiac arrest management besides fevers, you're going to have a Sears response because of all the stress. Anticipate the development of shock and treat like any other form of shock. Volume expansion, vasopressors, inotropes, steroids. SSCM guidelines recommend steroids for shock. A lot of these patients have sort of adrenal insufficiency that develops from their shock state, so the steroids will help with blood pressure. Target for a MAP of 65, glucose control of 140 to 180. Some of these patients are going to end up on insulin drips just because they're really edematous or a lot of pressors, and so subcutaneous insulin isn't going to be beneficial. Aim for normal capnia. Hypocapnia can cause cerebral vasoconstriction and reduce cerebral perfusion. Hypercapnia causes vasodilation and can increase your intracranial pressure and cause cerebral edema. EEG monitoring should be in place. There's a trial for the recommendation for prophylactic antibiotics for aspiration pneumonia, because usually when people arrest, they have some form of aspiration. And then neurological prognostication. So Is your patient having myoclonic jerking, seizures, or are they shivering? So everybody should be on some form of EEG monitor post-arrest, whether that be Cerebell or continuous EEG monitoring, unless they're awake after the arrest. This is all pertaining to comatose patients. Non-convulsive seizures are not uncommon in this population, so that's one of the reasons we want the continuous EEG monitoring. Seizure activity has to be treated aggressively. If it's true seizure activity, myoclonic jerking, you really don't have to do anything for. You might treat it for the family's benefit because it looks awful, but it doesn't really warrant any treatment. And then treating rhythmic or episodic EEG activity was studied that there's really no difference in neurological outcome. So if they have one seizure one time, it doesn't necessarily mean that you have to go all out and put them on a bunch of anti-seizure medications. Out of hospital cardiac arrest. It's wanting to restart. I don't want that. Out of hospital cardiac arrest carries a significant mortality. Therapeutic hypothermia, now named targeted temperature management, is proving to be overaggressive. So targeted temperature management really is the best term for it because we are targeting normothermia. So it doesn't mean we're not going to cool, but we're really not going to be making them 33 degrees. And EEG monitoring on all comatose patients. So I don't have a slide on this, but I'm going to kind of get into neuroprognostication. Sometimes I think that we don't give patients enough time before we deem them needing to have care withdrawn. Obviously, if they're brain dead, then they're brain dead and there's nothing you're going to do about it. If they're continuously seizing post-arrest, that's probably also a bad outcome. But some of these patients who are just taking a long time to wake up, you really should give them 72 hours or more before you deem that they're just going to have a bad outcome. In terms of neuroprognostication, we need to be doing tests to see what their brain function is. So EEG is really beneficial, MRI looking for an anoxic injury. So just because your patient isn't waking up 24 to 48 hours post-arrest doesn't mean that they should just have care withdrawn. Sure, we need to be thinking about it and what their general outcomes are, but we also need to give them time. And then getting gift of hope involved early also is needed just in case they are going to not be able to survive this, and then we can do organ procurement. So I know I had I know there wasn't a whole lot to say on it, but it's just I wanted everybody to be aware that the guidelines had changed. We're not going to be cooling people most of the time. So my big thing, which I need to talk about, is I feel Dr. Pardinas also feels the same way that post-cardiac arrest patients, unless they're like the guy that we just had who was awake afterward, really probably need to be a nursing one-on-one, at least for the first 6 hours, because we really want to target that temperature and make sure we're treating aggressively and monitoring for all of these post-arrest issues. So that's something I kind of want to talk about, maybe changing a policy on. Do you guys have any questions about anything right now? I know I had an hour and a half set aside for this, so it didn't take very long.
Hey, Taylor, this is Rick. What
Yeah.
guidelines changed? Or are you just talking about the practice of blessing?
No, the targeted temperature trial, the TTM2 trial that came out in 2021 recommends against cooling. So really aggressive cooling measures, because there's not any shown benefit between cooling to 33 and just maintaining normothermia.
Yeah, but that didn't change the American Heart Association guidelines, though. So I didn't know. It was there are a few things with that study with the very specific populations, which we don't get. In the States with the bystander CPR, high shockable rhythm is very select, honestly, and then long time to target time. So I just didn't know if American Heart Association came out with something to change that I was unaware of.
They haven't yet, and they probably will lag behind. And that's why I was saying, like, unwitnessed arrests or non-shockable rhythms, we might still cool. We're just probably not going to go all the way down to 33 degrees.
But why wouldn't you go to 33 with the Hyperion study? That was non-shockable rhythms. And it did have a pronounced benefit for cooling to 33.
That was before the TTM2 trial, though, which I know the TTM2 trial focuses on VFib and VTAC arrest. And this was just what the intensivist group had kind of talked about collectively, is perhaps just cooling only to 36 if we're going to cool, just because there's a lot of risk involved with cooling patients to 33.
Cool, thanks.
Mm-hmm.
We've always just said we're not necessarily cooling using that but targeting a temperature, whether that is 33 degrees in some cases or just normal at a 36 or 37 degree fevers, that's going to be on patient by patient basis. So Jennifer Taylor is getting that is in the past we have always, after that Hyperion trial, any pretty much any patient we had that was supposed to test, they went to 30 degrees. So we're going to be a little bit more selective now. This is going to be a conversation. Like Rick was asking, the AHA has not come out with new recommendations. That recommendation still sits that you can go anywhere from 33 to 36 degrees. It is kind of odd when you look at that Hyperion trial. What is it, 34 or 35? But that is the temperatures that they use anywhere from 33 to 36 can be beneficial according to the Hyperion trial. So the AHA still stands for that. We will probably see new guidelines coming. They come out with new guidelines every 5 years, and they did just come out. We just got in 2021 the 2020 guidelines, and then this TTM2 trial was presented after a AHA guideline. So I imagine we're going to see some new guidelines come out for the 2020 AHA guidelines. But right now, I think the biggest takeaway is this is going to be a conversation for a case-by-case basis. We will automatically, I think even in nursing, we are starting, we're going to 33, that's what we're doing, and there's going to be a bit more of a conversation. There will definitely be some patients we see that may benefit from the 33 degree, but for the most part, we'll probably be really, really focused on using, making sure that they're normothermic, because the worst thing we can do is allow them to end up having going to cause us way more problems, and they're likely to get fevers. So still, most likely, still facing the zone, because that's the easiest, most keeping them out of that's too. Even in the past, when we always went to 30, when we would rewarm, we don't want those fluctuations. So no matter what we're doing, whether we're doing hypothermia or normothermia, it's still going to be important to use that we have, because they're designed for that patients at the temperature that we want and not fluctuate.
And the people we're going to be more considering cooling would be non-shockable rhythms, especially with a prolonged downtime, to try to preserve some brain function. And then the temperature will just be based on what the provider is choosing. But I know that when we had a discussion amongst the intensivist group, we were talking about just targeting 36 degrees. Everybody's so quiet. I presented yesterday and everyone was so quiet too. Trying to get to the end.